Greetings. Let us talk about medical management of esophageal variceal bleeding. And I would like to share with you the rationale for different options that are needed to manage patients with esophageal variceal bleeding. These are my acknowledgements and the notice for you to read. And we have talked about this before in cirrhosis and ascites management, how portal hypertension develops. And let us review this. Once the liver develops cirrhosis, it results in resistance to the flow of blood in the sinusoids, leading to splanchnic congestion. With splanchnic congestion, there is going to be a decrease in effective circulating volume, which increases the renin angiotensin aldosterone system, increases the sympathetic outflow, and increases the vasopressin release. All of these work on the adrenals and kidneys, try to retain fluid, thereby increasing the effective circulating volume, and which in turn the heart increases the cardiac output, further increase in splanchnic flow, and the vicious cycle of worsening splanchnic congestion as the cirrhosis worsen keeps going. Once the portal pressure comes to a particular level, portal hypertension develops, and with portal hypertension, the blood has to take a route to get back to the heart, and that results in portosystemic collaterals. And if these collaterals are around the esophagus or around the stomach, they lead to the development of varices, esophageal varices, fundic gastric varices. As this splanchnic congestion worsens and this vicious cycle keeps worsening, other setbacks can happen in a patient with cirrhosis. These include hepatic encephalopathy, ascites, hyponatremia, and eventually hepatorenal syndrome. So keep this thing in mind, and this pathway is very important if you want to manage a patient with cirrhosis properly. As portosystemic as the portosystemic collaterals increase in size, the varices become bigger, and as the varix diameter increases, they are more prone to rupture and result in variceal bleeding. So, how do we manage a patient with variceal bleeding? And I want to share with you several different principles to help you manage a patient with variceal bleeding in the setting of cirrhosis of liver. Important to keep in mind whether the patient is at risk for aspiration of blood. If the patient is drowsy or comatose when he develops along with the bleeding, he or she is at risk for aspiration. So, important to keep in mind the ABCs of resuscitation, airway, and protecting airway is critical. That's one thing you have to ask yourself when you go to the bedside. Is the patient drowsy? If the patient is drowsy and is vomiting blood or any other fluid, he is at risk for aspiration, and protecting that airway is critical. If they develop massive aspiration pneumonia, they are likely to die. So you want to prevent that complication. So once you've addressed that, let us look at different mechanisms that lead to uh, portosystemic uh, portal hypertension, collaterals, varices, and bleeding. And the most important thing is splanchnic congestion. How do you address splanchnic congestion? You could give medications that decrease the splanchnic blood flow or splanchnic vasoconstriction. And we use octreotide. Other medications that can be used include, in addition to octreotide, one can also use somatostatin, or one can also use terlipressin. So when you use a splanchnic vasoconstrictor, i.e. octreotide, you decrease the portal hypertension and less flow to the varices, more likely to arrest that bleeding. You also need to keep in mind what all measures can you take to avoid worsening of this splanchnic congestion, that is limiting splanchnic congestion. In this case, when the patient comes in with a bleed, if the hemoglobin is above 7, 8, 9, 10, then you don't need to transfuse unless the patient is actively bleeding and you suspect that the hemoglobin is going to be much less than 7. In that case, you may give transfusion. So restrictive transfusion with a goal to keep the hemoglobin at 7 has been shown to improve the outcomes of these patients. So you don't want to transfuse too much. If you do, you're going to increase this splanchnic congestion, portal hypertension continues, and the varix that has bled is under a lot of pressure and it continues to bleed. So limiting splanchnic congestion is another principle to keep in mind. Another way to limit splanchnic congestion is to avoid the use of fresh frozen plasma or avoid the use of cryoprecipitate and avoid the use of platelets. These are not likely to benefit in the management of a patient with cirrhosis with a variceal bleed. If you give FFP, platelets, or cryoprecipitate, you are likely to worsen this splanchnic congestion. So you want to avoid that. So what are the principles that act on this splanchnic congestion? A vasoconstrictor, that is octreotide, or sandostatin, or terlipressin. Limiting splanchnic congestion by restrictive transfusion strategy to a hemoglobin of 7, and avoiding the use of fresh frozen plasma, cryoprecipitate, and platelets, which can increase the splanchnic congestion. So this is important to keep in mind. Another important thing with splanchnic congestion that's going to happen is bacterial translocation from the gut, resulting in infection. And it's important to prevent that infection by giving IV ceftriaxone. So these are all the things you want to keep in mind as you manage these patients. So we talked about splanchnic congestion. What are all the ways you can address that? Next, when it comes to variceal bleeding, the treatment of choice, endoscopic treatment of choice, is band ligation. Previously, we used to do sclerotherapy. Now, band ligation has become the treatment of choice because of less complications compared to sclerotherapy. If for some reason band ligation doesn't work, you go in, you're not able to control the bleeding by placing endoscopic bands onto the varices, there are a couple of other options. You can insert a zinc staken Blackmore tube, which has two balloons, a gastric balloon and an esophageal balloon, and inflating these balloons applies tamponade and controls the bleeding. It is only temporary. You cannot leave the tube for longer than 24 hours. Another option that is, this also works on the varices, and another option that is available, at least in Europe, is the insertion of a specially designed esophageal covered stent that also applies tamponade, which can be left for a longer period of time, a few days. So, so we talked about how do we work on the varices, band ligation, zinc staken tube, and esophageal covered stent. So you can also do something else. Can you impact or make the resistance to the portal flow less? That is by inserting a stent between the hepatic vein and the portal vein by an interventional radiologist. This is otherwise known as transjugular intrahepatic portocable shunt that uh, decreases this that takes away the resistance that happens in the sinusoids. The portal venous blood goes into the hepatic vein via the shunt, thereby reducing the pressure in the portal vein, and then that less pressure is going to be transmitted to the varices. So the pressure in the varices will decrease and the bleeding will stop. So we talked about several different ways to manage patients with variceal bleeding, and all of these things are important. We talked about what measures you can take to change the splanchnic congestion, to stop the varices from bleeding, and then to change the resistance to flow by inserting a stent. It's critical to keep in mind whenever a patient with cirrhosis comes in with variceal bleeding, you also have to monitor that the blood loss, the protein load, the hypotension that results from the blood loss can precipitate other complications. Especially, you should be checking the patient for hepatic encephalopathy and also for hepatorenal syndrome. I hope this is helpful. So keep in mind this diagram. Things that can work on splanchnic congestion, splanchnic vasoconstrictors, limit splanchnic congestion by restricting the transfusion strategy to a hemoglobin of 7 and avoiding unnecessary fresh frozen plasma, platelets, or cryoprecipitate in the patients with cirrhosis unless they have another issue that makes you think about it and give it. For variceal bleeding, banding, zinc staken tube, esophageal stent. Resistance to flow can be eliminated by putting the tips transjugular intrahepatic portosystemic shunt tips, and also look out for complications, hepatic encephalopathy, hepatorenal syndrome. I hope this is helpful, and I want to thank authors of this beautiful guideline statement from the American Association of Liver Diseases. Thank you.